on my computer this morning. Welcome, everybody. We appreciate you joining us. Again, apologize for the technical glitches that we had. We're joined today by Dr. Brandon Webb, who's an infectious disease physician with Intermountain Healthcare. Dr. Webb is also chair of the Intermountain COVID Therapeutics Committee and is deeply involved in examining and researching therapeutics for COVID. So we're going to talk a little bit about the Omicron variant. We're going to talk a little bit about volumes, where we are in terms of community transmission, guidance for the gatherings for the holidays coming up this week. And so again, we invite everybody to please submit your questions in the chat box. We'll make sure that Dr. Webb gets those questions and we get those answered. We also welcome everybody on our Facebook page as well, and we appreciate you joining us. We invite you as well, the public, to submit any questions you have via Facebook, and we'll make sure that Dr. Webb gets those answered. So Dr. Webb, I know it's been a few weeks since we've done this. Let's start with an update. Where are we in terms of COVID transmission in Utah as of today? And also, where are we in terms of volumes and the impact on the healthcare system here in Utah?
Yeah, thank you, Jess. We've got a lot to talk about today with the emergence of Omicron, and we'll get to a lot of the details about that particular variant. In terms of just a brief update, over the last several weeks, we've been quite steady in the community transmission. We're averaging around 1,000 cases per day, 7-day rolling average, which is still high, but just a skosh below what we've been over the previous several weeks. Because hospitalization is a lagging indicator, hospitalization rates have been pretty steady over the last 4 to 6 weeks, and our hospital volumes remain very high. We're seeing a lot of admissions for other seasonal respiratory infections. We're starting to see influenza in the community, and we are still in our COVID ICUs at or near 100% capacity. We're also experiencing record volumes in our medical floor volumes this winter as well. So hospitals across the state remain at or above capacity. And going into the next month, that's concerning because we're projecting that the Omicron variant will significantly burden the healthcare systems because of its transmissibility.
Let's talk a little bit about, before we get to Omicron, let's talk about Delta. In terms of transmissions here in Utah, where do you think we're going in terms of what we've been seeing in the trend lines in the last month or so as we head into really, truly the winter season?
Well, we did see in a lot of the country increases after Thanksgiving, as is expected. We've seen a trend in the Northeast and the northern Midwestern states where significant increases in the Delta variant have been observed over the last couple of weeks. In Utah, we have seen over the last 2 weeks a very small reduction in our case transmission rate, but the amount of that reduction is nominal. I think it's best described as stable over the last week.
Is that encouraging as we head into the season as to where we're at, or what are your thoughts on where we're at right now looking at the winter months coming?
Well, I think that the elephant in the room is the Omicron variant. So let's just jump right in with that. We're seeing across the country significant increases in case transmission that are now being driven by the Omicron variant. So in the northeastern states, there's been a meteoric increase in community transmission over the last week, with a relative increase in the proportion of cases that are caused by the Omicron variant. And the relative proportion of Omicron to Delta has been doubling every 2 to 3 days. That's consistent with what we now understand about the Omicron variant, which is that it is at least 2 and perhaps 3 times more transmissible than the Delta variant. What that means is that this new variant is more efficient at causing infection, and it's able to outcompete Delta. We've seen that now throughout Europe, where with a several-week head start, most countries in Europe are now experiencing significant spikes in the Omicron transmission, and seeing fewer and fewer cases due to Delta. In the U.S., because of that predictable pattern where the percent of Omicron of all overall cases is doubling every 2 to 3 days, we have fairly accurate projections now that by the first of the year, Omicron will be the dominant variant throughout the United States and in Utah as well.
We have at least one case identified of Omicron in Utah. What else do we know about Omicron in Utah to this point?
Well, all of our identification methods are lagging indicators. In other words, we have surrogate markers for Omicron based on one particular test that has a characteristic of the test that allows us to identify a pattern that we see with the Omicron variant called S-gene dropout. That particular test only makes up a fraction of the testing that is done in the state, but it does give us a very important window into the likelihood of what percentage of our cases are due to Omicron. And as of the last few days, we've seen an increase in the number of those tests that are showing the S-gene dropout. That suggests that in Utah, we may be somewhere between 3 and 6% of our total cases represented by the Omicron variant, pending confirmation by sequencing by the Utah Public Health Lab. That's consistent with the pattern that we're seeing in other parts of the country. In some of the northeastern states, the percentage as of this morning of cases that are due to Omicron is as high as 20%. And again, with that doubling every 2 to 3 days, we're several weeks away from that becoming the dominant strain throughout the United States and in Utah.
In layperson's terms here, because we do have a public audience on Facebook, what makes Omicron so potent, and what keeps you up at night regarding Omicron? What is so unique and so powerful about this variant?
Well, let's talk about two things: transmissibility, or how contagious Omicron is, and severity. Let's start first with transmissibility. Omicron has more than 50 mutations, and because of the evolution of the virus, this particular strain has developed mutations that give it an advantage over other variants, that allow it to outcompete Delta. Some of those mutations allow the virus to more efficiently cause infection. And we now have data that show that this particular strain is extremely effective at causing infection in the large airways of the lung to a much greater degree than the Delta variant. And because of that, there are very high levels of virus in individuals who are infected with Omicron, and therefore the ability of the virus to spread to others is enhanced. The virus itself is more efficient at infecting the cells in our respiratory tract. And so it is consistent with what we're seeing in the epidemiology data, that this particular variant is 2 to 3 times more contagious than Delta. Let's talk about severity for just a minute. Early on, Africa gave us some hope that this particular variant may be associated with less severe disease. Those very, very early data have now been supplemented by a much better sample size, not just in South Africa, but throughout the world, and particularly in the United Kingdom. And unfortunately, the hospitalization rate in South Africa and the United Kingdom has now shot up, which effectively demonstrates that the Omicron variant likely does not have a lower severity potential than Delta does. That's discouraging because the increased contagiousness of this particular virus is sure to increase cases. And with increased cases, we see increased hospitalizations in especially those groups that are particularly vulnerable to severe outcomes. And those groups include individuals who are not fully vaccinated, individuals with health problems and medical complexity, and individuals who have compromised immunity. And those are the populations that, like with Delta, we expect to see significant impact in terms of hospitalization, ventilation, and death with Omicron.
So you're saying that Omicron will be the dominant strain here in the U.S. and Utah. Did I hear you right? At the beginning of the year, we expect this to be the dominant strain?
That's correct.
Knowing that, what is your advice to Utahns? Are we prepared? Are we doing enough preventative measures based on what you're seeing out in the community now? It sounds like we have a very potent variant on our doorstep, if not in the door. What advice do you have for people? And then let's follow up that and talk about vaccines, a little bit about vaccines and what we know about their effectiveness about Omicron. But first, what do we need to know? And what do we need to do?
Well, what we can do and vaccines are two topics that go hand in hand. First of all, we have a couple of weeks to prepare, and it's important that with the holidays, we also take advantage of this time to make preparations so that when Omicron does significantly impact the landscape of COVID in Utah, that we're prepared, both from a public health standpoint, from a healthcare delivery standpoint, but also from an individual responsibility standpoint. There are some really important things that we can do. One is we really need to recognize as a community that the symptoms of COVID-19 overlap dramatically with symptoms of other respiratory viruses, and test early, test frequently and test early. There have been other states that have successfully adopted widespread availability of rapid testing, and we urge policymakers to continue to advance the availability of testing as much as possible. Testing frequently allows the community at large to identify when somebody is infected before spreading it to others. That's particularly important when we're talking about holiday gatherings. So, for example, strategies leveraging the home testing kits to test before attending large gatherings are very effective. It has the ability to identify a symptomatic patient who may have the sniffles or mild symptoms and are in the first few days of COVID-19. Secondly, it's really important that people in the community understand their risk. And what I mean by that is COVID-19 impacts people differently. If you are not fully vaccinated, the likelihood of having severe COVID-19 is much higher. That's even more particularly true in patients who are adults within the working ages of 30 and above, who have medical conditions like high blood pressure, obesity, diabetes, or other conditions that impair the immune system. It's very important for individuals to understand their risk and to take appropriate precautions. Thirdly, let's transition to vaccination. We know that the Omicron variant is the Houdini of COVID variants. It is able to escape to some degree immunity, whether from prior infection or from vaccination. The degree to which Omicron is able to escape immunity varies. It varies depending on whether your immunity was from a prior infection and how long ago that infection was and whether you've been vaccinated since, or whether the immunity was from vaccination and how long ago that vaccination occurred. What we do understand right now is that vaccination does protect against Omicron in two really important ways. First, immunity of any type, whether from prior infection or from vaccination with the standard 2 doses, significantly reduces the risk of hospitalization, ventilation, and death. It's really important to recognize that prior infection and vaccination to some degree limit the ability of the virus to cause severe disease. It's not, however, let me take a step back. The reinfection rate in individuals who have had previous COVID infection with Delta was very low. With Omicron, it's more than 10 times higher. And we now have data released from the United Kingdom just this morning that suggest that prior infection is about 500% less protective against Omicron than it was for Delta. The takeaway from that is that in order for individuals to be fully protected as much as possible, their immune system needs to have had 3 experiences with the SARS-CoV-2 virus. And what I mean by that is this. If you've had COVID-19 and are not yet vaccinated, in order to be protected against Omicron, you need to have 2 doses of vaccine so that your immune system has now had 3 experiences with the virus. If you're an individual who's had 2 doses of the COVID vaccines, you should get a booster so that the immune system has a 3rd experience with the virus. That significantly increases the antibody response and the T-cell response and increases the vaccine effectiveness against Omicron more than twice. Finally, we have some information just released this morning from researchers in Oregon that show that if you've been fully vaccinated and have a breakthrough infection, the breakthrough infection is a 3rd experience with the virus that significantly enhances the immune system's ability to protect against another infection. What that means is that for individuals, no matter which way they've accomplished it, getting those 3 touches with COVID-19 are the most important ways to be protected. And the ideal is, and again, the ideal is not to go out and get exposed. The ideal is to safely access vaccines and boosters to decrease the chances of having a severe infection.
Let's talk about preventative. Jamie Lampros from the Standard Examiner asks about masking. And again, for those of us here in Utah, it's really hit and miss depending on where you shop, where you go out in terms of the community. What do we know about preventative measures in terms of Omicron, and what's your guidance for gathering this coming week as we have the holiday season upon us?
Well, the tools in the toolbox that have been effective remain effective for Omicron. And we need to look at those as layers. There's no single preventive measure that is by itself effective. But when taken as layers, there are important ways that we can protect and limit the spread. One is reducing gatherings, reducing unnecessary gatherings. Second is ensuring that when gathering, limiting the number of individuals in a space and maintaining excellent ventilation decreases the chances of spread. The most important is not to gather, not to be in public if you have symptoms. If you have symptoms that are consistent with a respiratory infection, please don't gather with individuals. Get tested instead.
Okay. So a straightforward question. If I've been vaccinated, do I wear a mask out in public and in gatherings? What's your guidance for those who've been vaccinated? And obviously your recommendation for those who have not been vaccinated is get vaccinated and then do those protective things. But what's your advice for those who've been vaccinated and they're out in the community?
So again, knowing your risk is very important. Individuals who've been fully vaccinated, meaning they've had 2 doses, should get a booster if they qualify. Individuals who have had full vaccination and a booster or are full vaccinated and have not yet had a booster should still take preventive measures and not put themselves in positions where they may be exposed. That's true for everyone. Masks are one layer among others, including distancing and appropriate ventilation and gathering. Those are all tools that are at our disposal. And we have much more availability to high-quality masks now. So individuals who are at high risk should strongly consider using high-quality masks, including KN95 masks. those masks, when worn properly, do give more protection to the wearer. So there are a number of things that individuals in the community can do to decrease the transmission. No single measure will take the place of the package or the layers.
Okay. Some questions surrounding Omicron, and the question is, can this be considered a fifth wave? It sounds pretty ominous from what you're describing, the characteristics and the fact that we expect this to be the dominant strain in the United States and here in Utah after the first of the year. Is this the next wave?
Without question. Yeah, without question, we're going to see the same pattern that we're starting to see in Europe and in the northeastern states, where this will be a fifth wave. And in some cases, it's piggybacking on a fourth wave that never remitted completely.
Okay. A question from one of the reporters. The CDC recommended Moderna and Pfizer over J&J vaccine. Should those who got J&J be concerned, and should they be vaccinated or get a booster from Moderna or Pfizer?
Individuals who are eligible for a booster, which by CDC recommendations includes everyone 16 and up, should get a booster, whether they had the initial mRNA series or the Johnson & Johnson series. If you're eligible for a booster, you should absolutely get a booster. If you had the J&J vaccine series, it does appear that the adenovirus vectored vaccines are less effective against the Omicron variant, and by cross-training, there are data that suggest that having a mix and match strategy does increase the immune response of that booster.
Okay. Another question pertaining to what the current environment looks like. This one from Jed Bull from KSL. He says, describe what the current COVID care areas look like in the hospital. How crowded are they, and how do they compare to the surge last winter? So how do things look compared to where we were 1 year ago today?
Well, we've had hospital volumes over the last several months that have been similar to our peak volumes during the winter months last year. Our efficiency and our creativity has changed as we've learned how to deliver care in an environment where increasingly our staffing is limited. That's the biggest difference now compared to last winter. We have significant shortages in not just nursing, but also respiratory technologists and other allied healthcare professionals. And those who are working are, they're fatigued. So those are significant challenges that we're facing this winter that were issues last winter, but not nearly to the same degree.
What's the demographic? What are you seeing in the COVID patients that we're treating now that are in the ICU needing critical care? Is there any characteristics? Have they changed? Is it still what they were before or what they were last year? Any observations on kind of the patients who are needing ICU care and who you were treating?
Yeah, the patients that are going on to have severe COVID-19 are patients who have not been fully vaccinated, adults, especially adults with those comorbidities or medical conditions that I mentioned earlier, and individuals who are of advanced age and have multiple medical conditions or compromised immune systems. And as medical complexity increases, outcomes are poorer in COVID-19. We still have a large number of individuals who are being hospitalized who are in the working age adult range. So adults in the late 30s, a lot of adults in the 40s are being hospitalized with COVID-19, and the vast majority of those who don't have other extenuating conditions are not vaccinated.
How has this continued to impact other patient care in the hospitals, Dr. Webb?
Well, like I mentioned, we're bumping up against normal fall and winter respiratory infections as well. Our pneumonia care rates go up during the winter. Influenza is now starting to increase. Our ICUs generally have higher volumes during the winter months anyway because of respiratory infections and sepsis and other conditions. Having pressure from one singular disease like COVID on top of the normal volumes really strains the system. And it's been strained like that, like I said, at volumes that are very similar to our peak volumes from last winter. As we're looking ahead at the projections with Omicron's transmissibility, it doesn't look good. The numbers of hospitalizations are proportional to the number of infections, and the number of infections are projected to significantly increase over the next 3 weeks.
Okay. One other question. There are stories in the UK suggesting that Omicron and Delta could combine in some patients, creating another super variant. Is this real, or have you heard about this?
So viruses of all types can co-infect hosts. It's more of a concern in individuals who have compromised immune systems, where the virus is able to replicate unchecked in an individual and in real time develop mutations. Co-infection with the two strains hasn't been yet identified widely, but it is a potential. It's a theoretic potential. We're going to learn more in the next couple of weeks about whether these two strains can coexist or whether the Omicron variant can or will outcompete Delta. I suspect the latter. I think that it'll be much more likely that Omicron simply outcompetes Delta and we see much lower rates of Delta.
Okay. A follow-up from Jamie Lampros, just to clarify. She says, I'm still not clear whether vaccinated people need to be wearing masks. What's your guidance?
So the CDC guidance hasn't changed. The guidance is that individuals who've been fully vaccinated should consider or are encouraged to wear masks in public.
Okay. Okay. Well, I think I don't see any other additional questions in the chat. What takeaway would you leave Utahns as we finish this update and as we head into the holiday week next week? Any last parting thoughts you might share?
Jess, if we've got a few minutes, I'd like to actually touch on some of the treatments that have been in the news.
Oh, please, yes.
For Omicron.
Yeah.
I think it's good for us to understand what role those treatments play, what we know about them, the availability of those treatments. So I'll try to just briefly review those as well, and then we can finish up.
Okay.
With the Delta variant and all throughout last winter, we had the advantage of very effective monoclonal antibody therapy for high-risk individuals who are early in their symptom course. And we know that when we treat patients who are high risk, who are within the first 7 or so days of their symptom onset, these monoclonal antibodies were very effective, up to 80% effective at reducing the likelihood of going on to need hospitalization or death. They've been a very important tool in our toolbox. But with Omicron, the variant has a number of mutations in the spike protein that are in the same areas that those monoclonal antibodies target. And the result is that 2 of our 3 currently authorized monoclonal antibodies are likely not to work at all. They're likely to be completely ineffective against Omicron. That's discouraging from the standpoint of losing important tools for treatment. And I think it's important for the public to know that with Omicron's ability to escape immunity, that applies to the mAbs, and we have fewer tools in our toolbox to treat patients. There is still one of the 3 authorized monoclonal antibodies, a drug called sotrovimab, that does appear to remain effective, but it's in very limited supply, and currently we are not receiving any allocations of that drug from the federal government while they assess the situation and supply. So we're in a situation now looking ahead where monoclonal antibodies are likely to be less available. There are some antiviral drugs that are being developed or are in the authorization stage that are important to understand. The first one is a drug that we have been using for a long time now in hospitalized patients called remdesivir. There are data that will be published early next week that confirm that remdesivir is actually much more effective when used early on. And that makes sense with what we understand about how viruses work. If you target patients with antivirals within the first week of symptoms, the effect of the virus itself can be tempered before it causes damage to the organs. And that's what these data show with remdesivir. Is if you give a 3-day infusion to patients early within their first 7 days of symptoms, it reduces the likelihood of hospitalization by over 80%. We're working now to identify what our drug availability is for that particular drug to see how we can use that to supplement the drop-offs in monoclonals. There are 2 oral antiviral pills that are right now under consideration by the FDA. One is called molnupiravir and the other is Paxlovid. Of the 2, Paxlovid has much more promise for being an important tool in the public health strategy to prevent hospitalization. It is, in a randomized controlled trial, has been shown to be more than 80% effective at preventing hospitalization in high-risk individuals. But there's 2 important caveats. One, it has to be given within the first 5 days of symptoms, so that really highlights the need to test early when symptoms emerge and to know your risk, because this drug will primarily be targeted at patients who are at high risk. And then third, it has more than 600 drug interactions. It's a combination drug, that includes one drug that we've been using for more than 2 decades to treat HIV. And we understand the drug interactions that are associated with that very well. So patients who are on blood thinners or some heart medications or other medications that interact likely won't be a good fit for this particular one. And then finally, there's a third drug called molnupiravir that is currently being considered for authorization. There's some issues with that one. It works by introducing defective building blocks into the replicating genetic code of the virus. And because of that mechanism of action, it can also cause mutations in the genetic code of hosts as well. And so there are some very important reproductive safety concerns that were raised by the FDA. The randomized controlled trial that was done to study molnupiravir was largely conducted in other countries, and especially in the developing world, where the healthcare environment is very different than in the US. And as a result, there were really important variances in that clinical trial that raise important questions about whether the results were valid. At best, that particular drug has modest effectiveness, and in a U.S. healthcare environment may have very poor effectiveness. So of the 2, the Paxlovid drug looks like it'll have a much more important role in a public health strategy, and we're entertaining and exploring what the role of remdesivir may be and looking forward to hearing more about the availability of that third monoclonal. Before I run out of breath, there's one last good news in all of this. There is a long-acting monoclonal antibody that's been developed by AstraZeneca called Evusheld. And that particular antibody is still effective against the Omicron variant and is used not for treatment right now, but actually for preventive therapy in severely immunocompromised patients. So patients who've had a transplant or who have a blood cancer or who have genetic deficiencies of their immune system. This particular drug supplements the lower benefit that those individuals get from vaccination and can be a really important tool, we expect, for protecting the most vulnerable in our population.
Well, thank you for that update. There's a lot of things happening. The takeaway for Utahns as we end our update today, there's a lot of moving parts here, but what should people know as we head into the holidays? What would you leave them with?
We've got a couple of weeks to prepare for Omicron. We're looking forward to being together and enjoying the holidays. And while we do that, it's really important as a community to be responsible, to be cautious about the activities that we participate in. If you have not yet been vaccinated, with Omicron on our doorstep, I strongly encourage you to be vaccinated. If you've had prior infection and we're relying on that for protecting you against further strains, that no longer applies to the Omicron variant. And in that case, I strongly encourage individuals who've had prior COVID to get vaccinated. Individuals who've been vaccinated with 2 doses, I strongly encourage to have the booster dose that helps with the immune cross-training and increases the immunity against Omicron significantly. And for individuals who are planning events, I strongly recommend urging those who are gathering to stay home if they're symptomatic. For individuals who have minor symptoms, please get tested early. And I encourage the public to understand your individual risk.
Dr. Webb, thank you so much. We appreciate you taking time out of your busy schedule for this update, and we wish you a happy holiday, as we won't see you before next week. For everybody joining us, we'll send out a link up from today's briefing with all the information that has been provided today. So thank you for joining us. And for those of you joining us on the Facebook page, thank you for tuning in today. We appreciate it. Please be safe and happy holidays. Thank you so much.
Thank you.